3, 2. Good morning, everybody. It is 11:07 on March 7th. Wow, it's March already. 2025. I always give the date and time because we do talk about evolving science and things change from time to time. So if you're watching this later, check the date, check the data. Today, I am joined on Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association by Dr. Matt Martinez. Matt, how are all things in Morristown?
Things are great. We're booming. For those who are trying to get in, we are sorry for the massive delay to get in to see patients, but we think we have a solution. But all is well. And coming out of HCM Awareness Day and all of Heart Month in February, we are just booming. It's been terrific. Much of the work coming from this organization to really bring people to be aware of this, because as you know, you got to make the diagnosis before we can treat you. That's the most important thing.
Yeah, that starts a whole bunch of other things that happen later down the line, and getting to diagnosis is critical. And we didn't really pre-discuss this part of the conversation, but we're both doing work with a company called Viz.ai.
Yeah.
And we're looking for new methods to identify patients in larger populations. And do you want to make we're in Arrhythmia Management March. And as one of the major triggers to getting diagnosed for people is the feeling of palpitations and abnormal heartbeats, which might lead to an EKG, which might lead to AI assistance on reading that EKG. So how are things going? And are we optimistic about the future of AI in healthcare in this space?
Optimistic for sure. Cautiously optimistic as always, right? Because we have been down this road before, as you well know, where the shiny new toy turns out to be maybe more harmful than we thought it would be. In this case, though, if we say that our challenge is for diagnosis, then our solution that we've done for the last 25 years, which is to just try and educate the way we've done this, has been not as successful as we'd like it to be. And it's in pockets that it's been successful, and then whole areas where there's literally no understanding at all. So what I like about AI is that it never gets tired. It's willing to review the ECGs all weekend long, all night long. It's doing it in the background. So it is just telling me an alert. There's something abnormal about this ECG. And then I think it's going to come up with a couple of things. One is just going to find new people, right? We're going to find ECGs that are clearly classic for HCM, T-wave inversions, Q waves in a young person. And the way we're finding them now often is just by mistake, right? That they are found, they get your gallbladder taken out, and we find an abnormal ECG, and it gets found that way. The challenge with ECGs is that the promise has always been that it's going to save lives. And my message has always been, no, it's going to diagnose more people, and then we have an opportunity to try and treat them, because they don't all die, right? I don't think the message, so that's the challenge. And what I'm excited about this is that it will bring more people to the front. My main concern is where they're going to go. And I don't know how deep we're going to get into the politics of this, but access to healthcare is enormous. And making a diagnosis without a place to go is a disaster. And that's what we're seeing, right? For sure.
Okay. So let's go back to founding principles of HCMA. Okay. God, we didn't discuss any of this. Okay. So when I started this concept of, hey, can we get organized? Can we get the patients and the docs to come together so they can get good care and people don't get hurt? Reminder, why this all started. My sister died from mismanagement. Yeah. I was lost. I didn't know where to go for my own care, who to trust. So we had to find those trusted thought leaders, and they are historic names. They are Marin, and they are Lever, and they are Sherrod, and they are Seidman. They are the trusted names of the history of HCM and the evolution. So I drew a picture while I was thinking, and it turned out to be a triangle. You needed to build the top of the triangle before you could get more patients to be diagnosed, so that they had someplace to go. Not that we could just do something, but we could do the right things.
Yeah.
And we have 56 HCMA recognized centers of excellence now. We have a number of programs who are trying to develop up their infrastructure so they can join the network too. And we're doing a lot more work in bringing the PEDS programs in. You're going to hear a lot of that coming in the next year. So we're really building that up. But now we're getting to the tipping point of, we're talking to the public. We got TV commercials. Thank you, BMS. But what are we going to do with all these people when they come out of the woodwork? Are community cardiologists really skilled enough to take care of this unique population? I would argue not for the masses, and that we need center of excellence direction into the treatment path for that patient, and then work with community cardiology to unfold that over time. But here we are. When I started the organization, there was I think there was 290 million Americans, or people living in the United States. We're at 335 million today. That's a lot more people that need healthcare access. And I'm not talking about just HCM. I'm talking about standard care, vaccines, emergency medicine, like all the things. Why are emergency rooms getting more and more crowded? Why are we expanding more and more emergency rooms around the country? Because people don't have primary care physicians anymore.
Totally.
And how are we going to get them up to a cardiologist effectively and to the right one? Well, yeah, we're going to need help, and technology's got to help us. But there are longer waits than there were 3 years ago to get into most of our centers. We don't like that. Nobody likes to have to wait, and the doctors don't like to have to say you have to wait. But how do we triage people that when there's real issue, they get to the front of the line? Well, we kind of help with that sometimes, but it's going to become more of a problem as we figure out a very important question, which we did discuss before the podcast, and that is, how do we, as people living in the United States today, how do we view healthcare? Is it a consumer product, or is it something different? Because it's becoming a lot like a consumer product in some ways, and it's not.
Yeah.
It's the practice of science, medicine, human entities, and what we can do for them. So I don't know if anybody caught the news this morning. A weird shift happened yesterday. Walgreens was bought by a private equity firm, which also, that same Walgreens acquisition ties into a lot of other acquisitions within the healthcare community. And is private equity the way that American healthcare wants to depend? Because they're not exactly a stable group of investors. They make moves that are good for money and good for their investors, and I get that. But healthcare is different, isn't it? Or is it? And I think we need to start having a public conversation about, what does healthcare access mean in this changing world? Matt, I just ranted. Your thoughts?
Yeah, I mean, I think that's the question, right? And how are we going to figure that out? And we all need to have open and honest conversations about it, and make sure that we are doing it for the right reasons. And at least we're thinking about it now, right? At least I'm not sure this is the right process or the right delivery, but at least we're talking about it, and that this is going to happen. And I know you want to talk about Arrhythmia March, and I think this goes into that, right? Because we find arrhythmias, and then there's a misinformation and a mismanagement treatment option for a really common arrhythmia. In HCM, as an example, I would argue those are folks that really need to get in quickly, right? Because stroke is the real deal.
Oh, yeah. Atrial fibrillation and HCM leads to stroke, and we've done such a good job. Now, going back to what you said about diagnosing isn't saving a life. So I completely agree with that statement, and we never use that phraseology here at HCMA. You've just been diagnosed. How can we help you?
Yep.
You've just been diagnosed through one of our centers, and you think we saved your life. No. We just got education out there. Our job is to get education out there. We don't do the life saving. We leave that in the hands of the medical professionals, but we line you with those professionals who can save your life.
Right.
So we are part of a chain of survival. It's a complicated chain of survival.
Love that.
Diagnosis, getting your education, feeling supported and heard. It's a process. And we have to acknowledge that we're all part of a process, and we do our best in that part of the process. So as we're developing this process out in this new world, expectation setting. What can a patient expect out of the system? What kind of communication? Who should they be communicating with? Setting expectations so we have clear delivery. But a diagnosis does not equal a save. And a save is not always a dramatic moment of a cardiac arrest. It's stopping you from having the stroke. It's treating your heart so it doesn't go into a bad rhythm. It's getting in front of the family screening. It's these little moments that don't look like big moments that actually save lives. Agree, disagree?
Yeah, that's right. I mean, it's about gaining access to better care. And then how do we collaborate this with folks that are really in the trenches? So not everybody can drive 3 hours every time they have a symptom. We have to figure out ways to better collaborate and continue to build the wheel and spoke model. I'm not sure that private equity is the way to do that because of the way their thought process is not from the patient out. Generally, it's financially driven, and I think that's going to be a problem for sure.
We need good consumer protections for our cell phones, for our water bottles, and for our health. And there are different kinds of protections. You have data protection, you have contaminant, there's different reasons why having oversight is good for society. And how do we do that in a balanced way? So let's take our AI and HCM question into healthcare. So you go into the ER because you were a passenger in a car that was in an accident. Nothing to do with your health, nothing to do with your HCM. But as you say, my heart's racing, they say, we're going to do an EKG. And they do an EKG and it goes up to the cloud and it comes down from the cloud and it says suspected hypertrophic cardiomyopathy. What's the next step, Matt?
Yeah, so the next step is certainly going to be an echo, and then it's going to involve an expert to interpret that appropriately. And what I love about what you just said is that wouldn't it be great if everybody came in and said, hey, I wonder if I have HCM, and then we go down the algorithm? But that's not how it works. What happens is they come in and they have anxiety. They have palpitations. They have exertional chest pain. And we go down a different route, a coronary disease route, or we go down some other, alcohol-related atrial fib or thyroid disease. And what the AI ECG is, it's going to look at it and say, definitely atrial fib, but boy, it's got hypertrophy, it's got T-wave inversions. It's so much different than it was from 2 years ago. I wonder if you have HCM. And then the next step is going to be an echo, right? The echo has to then be done well. It has to be interpreted well. And I would argue that it could be all in keeping with a center, right? So that could be done, as you mentioned, a cloud. So wouldn't it be an overwatch of sorts where the ECG and the echo could be involved together? You can assess it, because atrial fib is not just HCM either. We worry about it in this podcast, but it could be amyloid, right? You're the thickness heart,
we're the thick heart disease group.
Yeah, this comes from Marty, but Marty and I used to laugh. We are the thickness doctors. So they would come for amyloid, for Fabry, and there are other entities that could come out of that. And I think that's going to go down to the clinician and then the cardiologist. And in reality, though, getting to an expert may not be the next step after that. It may be that your primary care doctor then says, well, that makes sense, right? They get a little bit of kidney disease, a little bit of anemia, and they ruptured their biceps tendon. Holy cow, I bet this is TTR amyloid. Or this explains why they had a son who had a car accident when they were 28 and nobody understood why they died suddenly. I wonder if they had HCM. So I think it still goes back to the clinician, but I like the ability for the ECG to point it out. And all of us need this, right? I know you a long time, and I know that you have a phone for a whole bunch of reasons, and one of them is an alarm, right? It reminds you to do certain things, like take your medicines because life gets in the way, right?
Oh, Jesus, I got blood work today. I forgot to take my tacrolimus. Hold on. Go.
Yeah. So this happens all the time, right? Where somebody will say, hey, we're getting on a call in 2 hours. I'm like, it's not on my calendar. Like, I don't think that's happening. So it's not on my list. So Janice is the boss of me at work, right? And Janice takes care of my calendar. And if the calendar doesn't say it, it's not happening. So, I think that's how I view AI ECG, right? It's going to prompt us all to think about it. It's so common, we ought to be thinking about it anyway, but that's just not how life works.
No, it's not how life works. And life with HCM can sometimes be view it as unpredictable, but I think we can predict a lot more than we
Yeah.
once thought. We're never, ever going to be able to out-predict biology. Not in HCM. I don't think we're going to ever get perfect at finding every single person at every single risk in time enough to stop bad things from happening. So again, setting realistic expectations. We can get really good, but we're never going to be perfect. And that you have to walk into this conversation saying nothing is guaranteed. However, how do I do best to protect myself based on what we know about my health?
Yeah.
So now how do we evaluate patients with HCM for all kinds of arrhythmias? What's the path?
So let's start with the atrial side, because I think there's an overt focus on the ventricular side and sudden death risk that we often forget about. The most common arrhythmia in HCM is atrial fib. It's also associated with the highest morbidity, right? Patients don't like it. It's always amazing to me that patients can say, I'm an atrial fib. It happened 2 hours ago. In fact, it was 12:12 when it happened. I think, well, how do you know that? We go look at the monitor because they're in the hospital and they lose the atrial kick. The atria starts to quiver and poof, all the energy goes down. They know it pretty close to on time. So there are two ways. Is that one, you have to suspect it, right? In HCM, atrial fib is really common. And then look for the other things that cause this. Do you have sleep apnea? Are you treating it well? Do you have high blood pressure? Are you treating it well? Are you obese? Are you exercising? All those things can need to be managed in order to lower the other things that contribute to the atrial fib risk. And they are numerous. Is the atrial size big? Is there, as I say, obesity and sleep apnea? Are we treating it? Anybody else in your family have atrial fibrillation? So I think first, foremost, good history, right? Got to suspect it in folks who are at higher risk. You got to look for it. And then I love the atrial fib risk calculator. I do it in all the patients. Those of you who see me, you can look at your note. It's usually the second or third paragraph, not in every young person, but in the older group, I do an atrial fib risk calculator on you. And it's really more for me to say to yourself, you got to remind me that they may be at risk for atrial fib, that they're 65 and their risk for sudden death may be low, no scar, no thickness, no story, but they're 65, right? And now we got them on valsartan, and their risk for atrial fib is not there. So I think looking for secondary causes and then using that atrial fib risk calculator, and then consider as a clinician, if you're listening and you're a patient, talk to your doctor about saying, is my risk high enough that I should be getting a monitor every 6 months? Do I need it every year? It's just a spot check, but it does increase the likelihood that you're going to find it.
So one of the biggest concerns patients have after being told that they've either had some episodes of AFib, and it's kind of like early in their AFib journey, is the question of anticoagulation therapy. Nobody likes being on an anticoagulant. They worry about bruises and falls and car accidents and all this other stuff. So you have to weigh your risks and benefits, which comes into this whole shared decision-making process.
Yep.
And you and I got to talk about that later. So as you are building that, how do you, as a patient, converse with your physician partner on what are the risks of AFib versus the risks of the therapies?
Yeah. So first things first, symptomatic atrial fibrillation is fairly easy. Like if you have symptoms and it's prolonged and you have atrial fib and HCM, you will benefit from anticoagulation. And it is because the risk in HCM and atrial fib is so much higher than in other conditions that you'll benefit from it. There are some scores that you can also do to look for bleeding risk. Have you had bleeding before? Do you have a history of colon cancer? Do you have von Willebrand disease? Something else that might increase the likelihood that you would bleed. And there are things, there are scores that the doctor can do to talk about your bleeding risk versus your clotting risk and atrial fib risk, and then you and he or she can have a good discussion about whether or not there's a benefit. And then how long are you in the atrial fib? Is it 20 minutes? Is it an hour? Is it 36 hours and you got to get shocked to get out of it? If it's longer duration and you're in atrial fib with HCM, your risk is higher. And then, as I mentioned earlier, the left atrial size really matters. The bigger the left atria, I'm more worried about it being dysfunctional, even if your atrial fib bursts are shorter. And we know that it's probably in the conversion, right? When it goes from sinus to atrial fib or back, that the stroke risk occurs. So I think it's having a discussion with your doctor. What's your bleeding risk? And then I always tell patients, somebody told me this years ago when I was a medical student, I need you to fear the disease and not the treatment, because the disease is merrily going along and picking people off and causing trouble. But the treatment, we've been begging for what we have now. 20 years ago, we only had warfarin, right? That's all we had. I'm sorry. This is difficult. I know it's a pain. There's no science to this. Let's give it a shot. And now that we have the better medical therapies that we have, the DOACs with data for this, man, I mean, we really have to take a half step back and say this is a gift and remind ourselves how lucky we are to be in the position we're in.
Yeah, I'm thinking back to episodes. My dad was a big AFib patient, and my sister Lori was too. And you see it on them. The minute they went out of rhythm, they're just like there were a couple of F-bombs that might have been dropped. It was my family after all. And it was, here we go again. And is it going to be a few minutes or is it going to be a few hours? Do I have to get cardioverted? My father was cardioverted 13 or 14 times. He would literally walk in and go, hey guys, I'll be in here, into the emergency room. And they would like do the thing. And like, he knew, and is like, hold my legs down. You know, I kick you. Like, it became just so normal to be so compromised. So we have a funny message coming across here, Matt. I think you have a mild stalker. Were you in a meeting at OHS this morning or OHH this morning? And you gave a great talk.
Yes,
Amy's following you.
Hello, Amy. Good to see you again. I just left you. Yes, I was. Oklahoma Heart, beautiful place.
Okay. That's too funny. So we've got a little stalker. That's kind of just funny. Love that, Amy. Okay. So AFib, really important to know about, really important to mitigate the risks. There are more therapies for AFib now rather than just anticoagulation. We're doing better with ablations, and ablations have evolved. So we'll just talk for a minute about this, because typically we say 2 or 3 ablations and you're kind of capped out, but it depends on when you had them done and the techniques that were used. Can you talk about a change in those techniques?
Yeah. So I mean, the procedure itself has evolved to the approach that we take to the if you're having surgery and you've already had you've had sort of a modified maze procedure, and then you're going inside and doing a catheter based. All of those things play into that. We also know that being a little more aggressive about getting you out of atrial fibrillation leads to better outcomes. So we used to often say atrial fib begets atrial fib, and we now know that you do better if you're back in sinus rhythm. So I like the approach that many of us take, which is that if you have an episode of atrial fibrillation that's prolonged, you need something to get you out of it. I start an antiarrhythmic drug, and then I refer you to my EP doc. So we're going to do both. And I say, look, if you have a recurrence on the sotalol or the Ticastin, then we're going to do an ablation on top of it. You're probably going to need both. And I do say just what you said, which is we often need at least 2 plus the antiarrhythmic drug. And the left atrial size matters. And then as we started, do you control your sleep apnea? Do you control your high blood pressure? Are we doing things to improve the substrate? Because atrial fib is the symptom. It's the fever, but we still got to treat the underlying infection, and that is going to be the left atrial size, the LV filling pressures. We also know that obstruction plays a role in atrial fib development, and it'll be interesting to see how this evolves with the new medicines that are coming out and how it affects the rates of atrial fib going forward. So again, super exciting. I think the take-home message is don't fear the anticoagulation. Figure out if it's best for you. Keep yourself in normal rhythm, and then treat the other things that are driving the atrial fib. That's really critical. Don't forget about the other stuff.
I will give a shout out to weight management as a technique to try to limit your atrial fibrillation, and keeping track of your left atrial dimension. On HCM Awareness Day, we talked about our checklist for every time you go to see your doctor, things to talk about. Knowing your measurements is important. We all focus on wall measurement and gradient, but there are more important numbers in HCM.
Yep.
making sure your ejection fraction is stable. And the number isn't as important as I'm typically between 65 and 70. And if all of a sudden you're 50 to 55, we have to look at that.
Right.
It's technically normal, but it's not technically normal for us. The other thing we want to check on is your left atrial dimension, because left atrial dimension leads to atrial fibrillation once the dimension gets big enough. So let's just focus on collecting data and having good conversations. So Dawn is here again. Dawn, I think you were with us last week when we were podcasting as well. And you've ended up in the ER with AFib, tremors, breathlessness that lasted 30 minutes, was told it was a thyroid issue. Only recently got a referral to cardiac and a more recent diagnosis of HCM because she shared it last week in a podcast. So Dawn, looking forward to getting, to know you a little bit better and helping you through this journey. It's a frustrating one at times. Hang in there. We got you.
But we got to change that nomenclature, Lisa. Boy, heart failure and HCM. Oh boy. I mean, patients do not like to hear that. It is clearly in the spectrum. And that's how we think about it in terms of nomenclature. But we've got to do a better job to change that, because it is the connotation that goes with heart failure is just brutal.
It's so, like, people ask me all the time, well, do I have heart failure? I'm like, well, technically, by the definitions of the word that name your disease, yes.
You do.
But how do you feel, and how is your body compensating to that disease process? Maybe you don't actually have failure. Maybe you have a stressed heart, not a failing heart.
Agreed. So, I mean, that comment just rings true with me. Patients do not like to hear this business. It's a different type of heart failure. It's a different treatment options for this. It's different.
Thank you. We've got a comment coming from LinkedIn, so I just figured I would put it out there because they like our talk today. We try to be informative and a slight bit entertaining. So, Matt, we talked a lot about atrial fibrillation, and I know you have a hard stop because you got to go do that doctor thing somewhere else. So let's just take a review real quick of the big, scary arrhythmias in HCM. So a little NSVT, non-sustained ventricular tachycardia at lower heart rates is not as dangerous as we once thought. So people shouldn't panic over a little NSVT, but more NSVT, they should probably be paying attention. You want to talk about that a little bit?
Yeah, 100%. So reminder for folks, when we talk about risk stratification, we're using things to identify if you, the individual, not the global, right? What are most people with HCM, but what do you look like? And it's going to be based on, have you had symptoms? Have you passed out before? Do you have a family history of sudden death in a patient with HCM who was young? If you died at 73 and you had HCM, that's a different discussion than
a 42-year-old father.
Right, than a 38-year-old who died suddenly while they were riding their bike. The degree of hypertrophy, thicker is worse. The amount of scar, and you mentioned LV systolic dysfunction. So as the ejection fraction dips under 50, where you develop an apical aneurysm, we know those are risk factors. But non-sustained VT is the one that is routinely misread. So it's very common to see PVCs in patients with HCM. VT is just a string of PVCs. So PVCs are premature ventricular contractions. So they're extra beats. They're skip beats. They are that flutter. Just a couple of extra beats. Patients say all of a sudden, ooh, what was that? Well, that was a skip beat, right? And that's really common. We see lots of those. If you string them together, you get non-sustained VT. 3 or 4 beats, depending on which definition you use, is defined as VT, and it's got to be fast. But we don't get nervous if we see a 6-8 beat run of VT, 10 beat, if it's 150, 160 beats a minute. And then what we're looking for is more than 2, 10 beats or longer, and over 200 beats a minute in a 24 to 48 hour period. And you can use extended monitoring to look.
So I think there's some discussion on that one, because that top number is the debatable number right now. Is 180 okay? Is 150 okay? Is 200 okay? I think age, gender, all the details matter here.
No. So this is important, because if you're older, I'm willing to allow a little more. If you're younger, I'm nervous. And then it's never this simple, right? It's, well, if they have 13% or 12% scar and a run or two of VT that are on the border, 185 beats a minute, and they're 9 beats, that's still enough for me to get nervous. And if you're 22, we're going to have a different discussion than if you're 52. And we just did a podcast on this for the HCM Society with Mark Link, and he had similar discussions about, well, over 50, I'm not worried. Well, I'm still a little worried over 50, and I'm a little more aggressive in that group than he is. Smart guy. He and I are friends a long time, so I trust his opinion. But all the things you just said. So it's VT, it's duration, but then it's age. Do you have other risk factors? Tell me about your story. Are you 28 millimeters? Well, if you're 28 millimeters, yep, you're right. It's not quite 30, but I'm still losing sleep over you. And that's shared decision-making, right? You and I are going to have a discussion.
Yeah, technically,
sure.
By oh my goodness, I just lost his name, Paulo Spirito. By his original paper with Barry, the number was 28 or higher, but everybody rounded it up to 30 because we like round numbers. So 28 is really kind of the number if you go back to the original paper.
Well, and if you look at the paper, like it's an incremental step, right? Yeah. Like everything else.
Like this, yeah.
Right. It's not a 27, you're fine, no risk.
Right.
It's it's incremental. So that's a discussion we have, right? You're 31, your wall thickness is 28, you got 8% scar and a 10 beat run of ET. I'm worried about you. I'm worried where this is headed, and I don't like predicting the market. So I'm concerned. Let's have a discussion. And I want to talk to your spouse because no one loves you like your spouse. So I want to make sure that they know what we're doing.
You need that team discussion there. So we're heading into closing time here because Dr. Martinez has to go off and be doctor. So Dawn, your comment is like you appreciate the language that we use here. It matters. So we take doctor, we turn it to patient, we turn it up a notch. And that's where we try to speak to you at. We try to meet people where they are. We know that a lot of these technical terms aren't very clear to everybody, even if you're in the industry and you're in pharma and you're working in the space, or you're a patient and you're been around a while. Some of these terms can be confusing, and science has this nasty way of changing things as we move along because we learn more. And the more we learn, the more we refine our comments, which is why I start every podcast with the date and time. Because literally a paper could come out in 3 days that changed what we say today. And maybe we weren't aware that it was coming, but we typically kind of know what's coming down the pike. So pay attention there.
Right. Even the name of the disease, right? It's been 70 plus names of the 50 years we've described it. And then in the last few years, Lisa, we're changing it again. Now we're NHCM and OHCM, which also is confusing.
So I'm going to tell a little story about names.
IHSS.
Yeah, idiopathic hypertrophic subaortic stenosis. Say that when you're 12 years old. You sound really smart. But okay, that's what I was diagnosed with originally. The first paper or first letter diagnosing the first patient, Claude Brady, was functional aortic stenosis in 1959. We've gone through a lot of names. But when an application went to the FDA and somebody who really didn't know HCM very well at the time, back in like 2013, said obstructive hypertrophic cardiomyopathy rather than hypertrophic obstructive cardiomyopathy, the nomenclature had to change again. And then we had to turn into this OHCM thing with no patient ever says I have OHCM. Because that's like going, oh, HCM. And that's just not what we do. We call it HOCM. We call it HCM with obstruction. We call it HCM without obstruction. And now we have NHCM, non-obstructive hypertrophic cardiomyopathy, APHCM, apical hypertrophic cardiomyopathy, MID-HCM, mid-cavity hypertrophic cardiomyopathy. Stop with the names, people.
Yeah, we got to get on the same page.
Stop. It's hypertrophic cardiomyopathy, period. Now you can define how it differs with obstruction, without obstruction, apical, mid-cavity, etc. But you start with hypertrophic cardiomyopathy because where your hypertrophy is secondary. Do you agree?
Yeah, well stated.
Okay, thank you for letting me have that rant. We have one question here. Yeah. I'm almost 48. I've had a defibrillator 2 years ago. My last EKG says ischemic infarct. Oh, thank you, Michelle, for bringing this up. Dr. Martinez, do patients with HCM have these ischemic infarcts, or is this part of the disease process that is HCM?
Yeah, so the EKG reader, the software reads things and they call it ischemia or infarct. So Q waves can be seen in a heart attack, and they can also be seen in a hypertrophic cardiomyopathy, very different processes, but they look similar by the EKG. Ischemia is the same way. So if you get T-wave changes, it can look like ischemia, which is lack of blood flow. Infarct is damaged heart muscle. So lack of blood flow leads to damaged heart muscle. An infarct is a heart attack. And ischemia is symptoms, chest pressure, breathlessness, and you can see all those on an EKG in an HCM patient, and you do not have a heart attack. But it's a good conversation with your doctor.
I had been told on multiple occasions going into my teen years, looks like you had a heart attack. Like, I didn't have a heart attack. I have IHSS. And they would look like I had 4 heads. Especially when a 15-year-old says that to you. And they're like, yeah, they don't know anything. So, Michelle, good observations. I encourage you to do an intake and navigation call with us. And on a side note, loving the blue coat in the picture, loving it. Okay. So we've got that. Any other questions? This would be the time to ask.
Yeah, these are great.
Matt, as we come off of Heart Month, we did a lot this Heart Month. We had interactions with probably all told about 1 million people through social media, just through our network alone.
Wow.
And then there's all this other effort going on out there. What has the change in awareness globally? What do you see happening?
I mean, it's definitely growing. I mean, we are seeing more focus on HCM than we ever have before. There's more excitement about managing HCM, and because there are new therapies that are continuing to come down the pipeline. What's still amazing to me is that there are still huge gaps, that there's still so much more work to do. Sometimes I'll give a talk and someone will say, oh, I've never heard of this. Well, how could that possibly be? How could that possibly be? I feel like I've given the same talk 50 times.
I have been in the room where somebody's like absolutely shocked that, 3.0 wall measurement is a risk factor for sudden death. I'm like, who are you? Who are you practicing? And what has happened to all of your patients? Yeah. I'm scared.
So it's coming. I think that there's more awareness now. With that is as we talked about, the importance and the onus on us to create easier pathways, safer pathways, and more constant communication with folks that you're hearing asking questions that are an easy lift for an HCM expert that get kind of pushed to the side if you're not seeing them. So we've got to create a better pathway. But the interest, the excitement, the focus like never before. As Lisa knows, we used to be, with Barry all the way at the end of the hallway, the last session of the day.
The last session.
So now, boy, we got whole sessions. We got whole sessions on. We got a whole day of HCM Society right before the AHA. How could it be any better than that?
We had late breakers, like we got on the main stage with a bunch of trials over the past 2 years. So that is awesome. We do have one last question, and this is a tricky one, so I'm going to pose it.
Yeah.
Elisa, I'm assuming we have a clear diagnosis of hypertrophic cardiomyopathy and a stress echo with an EF of 51%. Now, let's talk about those under 55, over 50. What's going on here?
So this is a disease typically of hypercontractility. So we usually see ejection fractions of 65, 70, 75%. So when I see under 55, I'm nervous. So I'm nervous where, is it 51? Is it 45? Is it 55? And for the question asker, know that the ejection fraction by echo is plus or minus 5 to 10%, every bit of it. So if I saw you, 1, I'd want to look at the echo myself. 2, I'd want to make sure that we truly had HCM. Are you burning out? Is the ventricle starting to get a little weaker? And can we do something to bring that back up again? And then I always do a tiebreaker in this scenario. I do an MRI of the heart. Really critical for the person who asked that. You got to ask your doctor for an MRI, and it's for 2 reasons. 1, it'll better quantify the ejection fraction, a tighter window of variability for an MRI compared to an echo. So the MRI may not be perfect, but it's got a more reproducible number compared to an echo. And then I want to know if you have a ton of scar, because if the ejection fraction is dropping and you've got a bunch of scar, you and I need to discuss 51 versus 49. For me, it's the same. And we got to have a discussion about whether or not you need some more safety measures.
Okay. My cardiologist didn't explain any of my tests to me. I don't know my wall measurements, gave no advice. I figured it out on my own and because of this group. please call
Love
our office. Please let us engage you with an expert in the area. We even have the Lori Fund to provide you travel stipend if you need money to get to a center. We'll pay $599.99 to get you to where you need to be. We are here to have your back. Okay, Donna, I'm going to let that question go to the website. Hyperdynamic hearts are 70% EF or higher. It's the common state for HCM, and we all have kind of hyperdynamic hearts. So that information on that's on the website. And I want to be respectful of Dr. Martinez's time, who told me he had to leave like 7 minutes ago. And I'm going to end the stream and talk to him for 2 minutes before I let him go. So thank you to our sponsors. Thank you to this engaged community coming to ask questions. Thank you to the entire staff of the HCMA and all of our contractors and partners who make things like this possible. Shout out to Joey Graham, who does our podcast editing, and of course to Carl the dog, because we all love Carl. I got to bring a picture of Carl with me someday. You got to understand this dog. He's kind of an awkward dog, so we love Carl. So thank you all for an amazingly successful Heart Month. Wait till you see the metrics. They look amazing. And we'll see you next week on Tales from the Heart, where I believe I'm with Marty Marin. And I have some other secret spice people coming in. So we've got some interesting stuff coming. Thanks for staying tuned, and we will see you next time. And
thanks for having me. See you guys soon.